If the private company had earned a lot of profit in the year, then the profit can be converted into a bonus to all individuals within the company. But if we assess by different departments in the company, then the P4P can be broken down into different departments' performance. Now come to the definition that we adopt in healthcare. So I put a few references, which is from, actually it's from the reference I give you later in the next slides. But these slides give the source of the definition. The first definition is from RAND Corporation from the US, that they classify or define the P4P. It's the general strategy for promoting quality improvement. Now it's become more specific that we will focus on the quality improvement. The P4P aimed as a strategy. P4P is rewarding providers, and who are the providers can be physicians, can be clinic, or can be hospital, or can be departments with everybody in that department. So this rewarding the provider that perform to a certain to meet the expectation of the performance with respect to healthcare quality or efficiency. I put in red that promoting quality or promoting quality improvement, so it's more or less the same thing as we set the quality as indicators for assessment. If we set quality improvement as criteria, then we expect to have quality improvement in the end. So it's more direct. But within the RAND definition, they also put the efficiency within the framework of P4P. This is quite what we interpret the P4P, especially in Thailand. When we adopt the concept of pay for performance, we more or less adopt it on the efficiencies in the efficiency ground rather than in the quality framework. But when we review the definition, it put more emphasis on the quality improvement rather than efficiency. The second definition that I put it here, that it's a range of mechanisms. Pay for performance is a range of mechanisms designed to enhance performance of the health system through incentive-based payment. So the definition by the World Bank may not put the emphasis on the quality, but it may be something hidden within the performance. So it's not well specified or not explicitly specified as in the RAND Corporation's definition on quality. And in the literature, towards the end of my presentation this morning, the P4P, especially in the US, they put in another words of value-based purchasing. This is P4P is more or less equal to VBP. VBP in the US, VBP is the value-based purchasing. This is more or less like when in healthcare we want to increase, if we want to intervene the market, then we have purchaser and then we have a provider of healthcare. And P4P is the mechanism of a purchaser intervene the market and expect the value from purchasing of healthcare. So these are the few of the definitions that may have different shade of meaning. So it depends, or it may be interpreted differently within different contexts of health system. So if we look at the theory behind the P4P, so what's the theoretical background of pay for performance? As we put many references referring to business, referring to economics principle, then it's the economic arguments that because we have a principal agent theory, that we divide the purchaser and provider, and they are living into the contractual relationship. So it's the signal from the principal to the agent that the principal asks the agent to do what the principal would like to achieve, and they let the agent to achieve the goal, and that goal to achieve that goal, I put in the end that with lower cost. That means that kind of mechanism of P4P, there should be some intervention. So the intervention, we can interpret it as cost. So the principal put intervention to the agent, and the agent produce the product. And the agent will produce the product which is higher than the cost of the intervention that the principal put into. So this will be incentive for making P4P work and sustainable. So the principal can be the patient, individual patient themselves, but as we know that healthcare market is imperfect, and the patient usually have less information to intervene. Then it's more or less the principal moved to be the collective purchaser or the funders. Then we put in that the strategic purchaser. Then the funder should exercise as the principal role to purchase the healthcare strategically in order to get the higher outcomes, the highest outcome. And the agent classified as an individual practitioner or the hospital or some actors within the healthcare. The second point in this slide is that the prerequisite, or I put that the prerequisites, that mean some of the scrutiny In the textbook, they said as the scrutiny. If the principal want to exercise the P4P, then the principal must have these conditions, must foresee that these conditions are fulfilled. They have to scrutinize all these three conditions. The first is the measurements. The measurement plays a key role. That means, from the previous definition, you remember that it depends on the KPI assessed. So if you have the system to measure the KPI, or that selected KPI is correct, as I said, there are many PI. PI means performance indicator. We have many PIs, but which is the most relevant to the outcomes or indicators that's related to what we are looking for. That's the first prerequisite. The second is numerous judgment, such as magnitude of the incentive, whose performance relativity. So as I discussed before, it depends on the context, very contextual, specific. So if we want to exercise the P4P, there are many judgments related to it. Example in this put that magnitude of incentive. We have experience in Thailand that when we want to introduce P4P and the P4P that we introduce, it's very minimum money. It's very minimum, not much money compared to the salary. Then if the signal is not strong, very little, then the P4P or the outcome that we expect may not be very high or very sensitive. And also, whose performance relatively, my performance as compared to my peers, or our departments as compared to the other, or the other hospital, or as compared to the baseline, or as compared to the norm. So these are the numerous judgments putting into here that we have to be clear that all of these considerations we think before. And the third prerequisite or scrutiny before we plan P4P is the intrinsic motivation of professionals and organization. This is the more or less like behavior or historical. There are also many things within here that look into the motivation itself, that within the professionals may have some of the cultural specific, that we cannot put the pure economic principle through the that professions in that country. So it's more or less you have to study what the true behavior there. So this are a few slides that need to be clarified first.
Saya merangkumkan sedikit, yaitu Profesor Basit memaparkan mengenai definisi Pay for Performance atau P4P secara general, yaitu sistem remunerasi bagi pegawai di mana sebagian atau seluruh kompensasi yang diberikan itu terkait penilaian terhadap performa. Yaitu di sini jika dalam konteks bisnis itu biasanya dikaitkan dengan KPI atau Key Performance Indicator. P4P itu sendiri di dalam pelayanan kesehatan dapat diartikan sebagai strategi untuk memacu peningkatan kualitas dalam memberikan reward atau penghargaan terhadap tenaga kesehatan itu sendiri dengan mempertimbangkan kualitas atau efisiensi. Namun di sini bagaimana menginterpretasi kualitas atau efisiensi sendiri itu perlu lebih diperjelas lagi. Kemudian juga dapat diartikan sebagai suatu mekanisme untuk meningkatkan performa sistem kesehatan dengan pembayaran yang berbasis pada insentif. Selain itu dapat juga diartikan sebagai pembayaran yang didasarkan pada value atau nilai yang akan didapatkan. Di sini adalah salah satu usaha dari purchaser itu untuk mengintervensi health market itu. Jadi dengan cara pembayaran dengan pay for performance itu. Kemudian ada beberapa teori di balik P4P itu, yaitu teori principal agent, yang dalam hal ini mereka terkait dengan kontrak. Sehingga akan terjadi mekanisme bahwa prinsipal itu ingin mencapai tujuannya atau goalnya dengan biaya yang diharapkan dapat ditekan atau dengan biaya rendah. Prinsipal dalam hal ini dapat diartikan sebagai pasien atau strategic purchaser, sedangkan agen dapat diartikan sebagai rumah sakit atau juga dokter pribadi. Ada beberapa persyaratan atau kondisi yang perlu dipenuhi untuk P4P ini, yaitu antara lain adanya sistem pengukuran untuk KPI dengan baik. Harus ada indikator yang jelas untuk performance yang akan diukur. Selain itu juga perlu adanya penentuan magnitude dari insentif itu sendiri, sehingga insentif yang diberikan itu harus spesifik untuk memotivasi tenaga kesehatan itu untuk meningkatkan performanya. Selain itu juga akan terkait dengan motivasi intrinsik atau perilaku dari tenaga kesehatan itu sendiri dan organisasi. Hal ini dipaparkan oleh Prof. Supasir dapat terkait dengan culture di tempat tersebut, sehingga akan sangat spesifik dan bisa berbeda dari satu tempat dengan tempat yang lain.
Yeah, to follow on the next part will be on the example or the arrangements of the P4P that this textbook summarizes. So within the healthcare, the textbook by Kashin in 2014 classify the countries in the OECD. The OECD countries, in 2012, there are about 33 countries of the member of the developed countries. And they classify that P4P models apply most in primary care system. When I count, so this list is not exhaustive. But you can see in the list that Austria implement none of the P4P at all. So Canada, no P4P. So, but towards the end there will be Turkey, UK, and the US. The UK and the US apply P4P for three categories here. That means UK and the US as the countries here in the Netherlands on the list here, in Korea or in France, that they apply within three sectors, like primary care sectors, and also specialist care and the hospital care. So we can see that the most prevalent 18 countries out of 33 countries apply in the year 2012 of the publish of this textbook. 18 out of 33 countries apply to the primary care. But apply doesn't mean that the whole 100%. So some countries may apply just a few percentage, 5%, but some may apply as the nationwide, like in the UK of a primary care system, they apply the quality outcome framework to all. So the second most prevalent is the apply the P4P for the hospital, and the third rank is for the specialist care. So what they apply, the objectives of application of P4P in primary care. So there are 6 or 5 specific categories here. So the first is to focus on preventive care. The second is to get outcome quality from the management of chronic disease. The third category is by the definition of RAND's Corporation, aiming for efficiency. The fourth is to increase patient satisfaction. So patient satisfaction is another aspect of quality. It's the lay people interpretation of quality. The uptake of the IT service. This is also classified as the P4P. It may be perhaps because of if the primary care adopted the IT, then it make the system become more efficient. Not only more efficient, but maybe of good quality. So these are the consider the objectives of why they choose to implement on the P4P for the primary care. For preventive care, you may think about the coverage, the coverage of vaccination. If the coverage of vaccination is high, then the GP or the primary care team will get the bonus. Or like in the UK, if they want to stimulate on the high percentage of pap smear screening, cervical cancer screening, if it reach 70%, then the GP will get a bonus for that. This is a kind of arrangement. For the management of chronic care, it can be the like an example of diabetes or heart disease. Then there should be a certain uptake of the service of diabetes screening, the secondary screening for eye tests within a year, or for heart disease, the use of beta blocker. This is a kind of indicators that they can put into the whether the primary care or the specialist care do this. So this slide is also another example of P4P, the objective of P4P in that used to intervene the hospital. So it's focus on clinical outcomes of care, the use of appropriate process, patient satisfaction, and patient experience. Clinical outcomes of care can be objectively assessed as the readmission rate. So the readmission within 30 days after discharge, if it is very high, then it considered to be unacceptable quality, because the patient, if influenced by case mix payment like DRG, then the hospital would like to shorten the length of stay, and the condition of the patients may not be favorable in staying at home and come back to the hospital later. So the first definition for clinical outcomes can be the readmission rate. And the second can be the outcomes on the mortality, so the death within the hospital, whether the patients die in the hospital or the patient die after 30 days from the hospital. And sometimes they may consider as long as 1 year, but 1 year is too long to be the hospital outcome. It will be mixed with the environmental conditions. So these are the example of the how they implement on the P4P.
Jadi P4P model digunakan di beberapa negara OECD. Pada tahun 2012 ada sekitar 30 negara maju yang sudah mengaplikasikan P4P ini. Paling banyak P4P ini diaplikasikan di puskesmas atau di primary care, fasilitas kesehatan tingkat pertama. Kemudian setelah itu jumlah yang banyak menggunakan itu adalah rumah sakit, dan yang paling sedikit atau jarang digunakan itu adalah untuk spesialis atau pengobatan yang spesialistik. Di Austria mereka tidak menggunakan P4P sama sekali, sedangkan di beberapa negara lain seperti Belanda dan Perancis mereka menerapkan P4P ini untuk 3 jenis pelayanan itu, yaitu primary care di rumah sakit maupun untuk yang perawatan spesialis. Tetapi pengaplikasian ini juga tidak berarti bahwa diaplikasikan secara 100% untuk pemberian insentif bagi tenaga kesehatan. Bisa jadi di suatu negara diaplikasikan 5%, atau di suatu negara juga bisa diaplikasikan hingga 100%, yaitu di dalam seluruh rumah sakit. Kemudian apa tujuan atau objektif yang mau dicapai Pay for Performance ini di primary care? Itu antara lain untuk pelayanan pencegahan, kemudian juga untuk manajemen terhadap penyakit kronis. Selain itu juga untuk meningkatkan efisiensi dari primary care itu sendiri, dan juga kepuasan terhadap pasien, dan juga untuk meningkatkan penggunaan teknologi informasi. Selain itu ada tujuan-tujuan lain tapi tidak disebutkan. Contohnya adalah menentukan suatu persentase cakupan vaksin di suatu primary care, dan jika dokter bisa mencapai cakupan tersebut ataupun melebihi, dapat diberikan insentif atau bonus kepada dokter tersebut. Kemudian kalau di rumah sakit, objektif yang ingin dicapai oleh Pay for Performance itu biasanya adalah terkait dengan clinical outcome terhadap pasien, yaitu antara lain berhubungan dengan readmission pasien atau dirawatnya kembali pasien dengan penyakit atau diagnosis yang sama. Selain itu juga dikaitkan dengan kematian. Kematian pasien ini bisa terkait dengan kematian yang terjadi di rumah sakit maupun Kematian yang terjadi 30 hari setelah pasien keluar dari rumah sakit.
Yeah, next part, I will give example in Thailand, but I have to just present only paying to personnel. That means paying to the health workers, not the paying to the hospital level. Because paying to the hospital level, we have discussed earlier on the capitation and also for the DRG. So we have that kind of paying to the hospital or the provider level. But this is the payment to the personnel or the health workforce within Thailand. And there are some part that we introduce the P4P, that we interpret P4P as in the slide P4P we introduced in the year 2010. Before we introduce P4P, the payment to the health personnel in Thailand, in the Ministry of Public Health, we start this over 3 decades, since the year 1990s. At the time, that's before 10 years before the universal coverage scheme. But that was around the Social Security scheme just happened. But at the time, we want to influence, want to reach the retention of medical doctors within the public sector, because at that time, before the Tom Yam Kung syndrome, the economic crisis in 1997. Before that, before the economic crisis, private sector boomed a lot. Then there are lots of drain of doctors, pharmacists, and dentists from the public sector. Then we introduced a non-private practice allowance for physicians, dentists, and pharmacists. This is a flat rate payment to those who declare that they will not work in the private sector, that they get the additional allowance for this. It's 10,000 baht per month for doctor and for dentist, and 5,000 baht per month for pharmacists. After that, we introduced the workload payment, which more or less can be interpreted as like what performance that we want to achieve. It's if we want to achieve a higher productivity, then we want to give the workload payment. Workload payment, this is for the after office hour. Like yesterday we discussed about the doctor fee. Doctor in Indonesia is more advanced, that you pay no matter work in the office hour or after office hour. But at the time, 1990, around that, we just introduced the workload payment, but limit to the after office hour. And also, we also have a rural area allowance, hardship area allowance. This is to achieve the retention of health workforce in rural areas. And also the next is a special health task allowance for health professionals. So there might be some of the special tasks that we need the health professional to do. And lastly, we introduced the P4P, which P4P, some of the observation may be that because there are many fragmented the payment, and there seems to be inequity among the health professions. That means some professions had very high payment, but some of the workforce had very low additional payment. So the slides may not look very good on the explanation here, but this is the total payment pie chart that we construct from the data in 2014 from around 1,000 units of hospital throughout Thailand, 76 provinces, perhaps not include Bangkok. In total, we had around 27 billion baht as compared to the SARI. The total SARI was 60 billion baht. So this is about half, almost half of the SARI expenditure. And the additional payment, we start from vertical line here that this is the no clinic, doctor no clinic, dentist no clinic. So this portion. So not very high, but the highest here is what? It's maybe some kind of the overtime payment. OT service here. So we have several kinds of payment, and P4P is around here. So P4P. So as I said, the P4P is not very big portion. P4P for service and P4P for back office, because there are some criticism from people who work at the back office, like the finance people who had not much gain from this criteria of payment. So, because we want to know the impact of each kind of additional payment, there are several kinds of additional payments, and there are criticisms or the arguments against equity among professions, whether who get and the payments consistently increase so that it eats up the universal coverage or the capitation. You may see in yesterday's pie chart that some portion related to the HRH, hardship. So these are the compensation related to this kind of pay to personnel. So our study was to review the existing condition and to do some of the simulation study on the financial impact, and we compare whether we want to go ahead with this complex design or we want to have a simple design or a simpler model. And this is our interpretation of the principal agency theory, that the hospital of the Ministry of Public Health are considered as they are having several firms, maybe having many principal, or they are not, in short, they are not homogeneous. The hospital adapt the rules from the Ministry of Public Health, and then they apply to their own hospital with a specific condition. And the P4P payment portion that we interpret, that we introduced the latest in 2010, this P4P to increase efficiency both within and after office hours. But they have to collect many indicators, and the load of collecting indicators is much more as compared to the amount of money. So this is some of the what happened in our experience. And once we compare the expenditure, this is another chart comparing the salary part and the additional payment part. And the green bar is the situation in community hospital, and the orange bar is from the provincial hospital. You can see that the salary is the biggest part, but the second biggest is the OT or the overtime part, and the overtime payment is high in the provincial hospital. You can see that the introduction of the P4P, even though I say that it's not very high as compared to other things, but P4P just focus in the provincial hospital. That means the primary care level hospital, they do not like P4P concept because their people on the list is not as high as in the provincial hospital, and the visits not as many as in the provincial hospital. And if we see the source of finance, roughly here, that when we compare the source of finance between the community hospital and the regional hospital, we see different pictures of the hospital revenue, which is in red. You can see that lots of red, the totally red in the OT, both in community hospital and in provincial hospital, because the overtime payment is paid from the hospital revenue. And what else paid by the hospital revenue? P4P part in the regional hospital or the provincial hospital, that totally paid out of that. And also the other things like the non-private practice in provincial hospital is paid by the provincial hospital, but the government gives subsidy to community hospital for non-private practice payment. So this is some kind of, if we think about as the prerequisite, where the money should come from, that also another important issue. So we propose the ideal model that the complex, many types of payment should be changed, but it will be very brave for the Ministry of Public Health to change, because the regulations that we are practicing, it's come from small regulations governed by the Ministry of Finance, and this make life more difficult. Making a big change is also difficult. So that highlights some of the limitations within our system. So changing status quo to the simpler design sounds encouraging, as we can see direct impact of payment on equity efficiency of the health system. However, the change requires huge support from within and outside the Ministry of Public Health, so that we cannot change much. Next, to the conclusion, or you want to? Yeah. So we move forward to the conclusion on the advantages or the strength and the weaknesses of the P4P found not in Thailand but some other countries which had the publications on. From the previous slides on 2012, Danish, there's no Denmark in that table. But recently, last year, in 2016, there was a publication published in the European Journal of Health Economics saying that a Danish P4P scheme to provide patient with case manager. So there's a experiment or the new things happen to Danish healthcare. And they found that there was a 5 percentage point higher performance at the hospital department that are subject to a direct financial incentive. So if it's remind about the cost of intervention and the outcome, so the outcome saying that there is an increase of a 5 percentage point in the performance of the hospital department. So this is the positive side. And the conclusion here is that it is because the payment is directly to the department rather than to the hospital level. So our review had said that payment can be to individual, can be to the department level, can be to the hospital. So if we design the P4P to the hospital level, it may not give a good signal to the actor themselves. So this is one of the literature that I put here. The second literature seems to be dubious about the advantage or the strength or weakness. So it's semi-acceptable. It was the publication in New England Journal of Medicine in the year 2007. It's the evaluation of the hospital in the US, the hospital that engage. They compare about the intervention group is that the hospital that had public reporting and P4P. So public reporting, there was a trend almost more than 10 years ago that public should know what had happened in the hospital, or more or less the quality evaluation of the hospital should be known to the public. So there was a move that hospital should publish that how many patients die in the hospital and compare between the hospital, so the patients can choose where to go for this kind of surgery, because the mortality rate is lower. So this is a public reporting. It was compulsory, and this is to compare the hospital that had public reporting plus P4P, compare with the hospital with only public reporting. And the result found that there was about 2.6% to 4.1% increase of the performance. So it said achieved modestly greater improvement. So great or not great, modest or modest. So it's very dubious that not so great at all. And it's only this within 2 years. So it's a question that whether this increase would outweigh the cost of doing the P4P. So the later publication by the group of Harvard Medical School. So they published in the BMJ last year, and they said that the value-based purchasing, or the hospital value-based purchasing, as as I said before, that in the US, they interpret P4P as the value-based purchasing, and this is the P4P in the hospital. And the evidence at the hospital P4P has led to lower mortality rate. Is lacking. So it's not so convincing after looking at the trend for more than 10 years, and it concludes that the evidence is lacking. The nations that considering similar pay for performance program may want to consider alternative models to achieve improved patient outcome. So it's proof useless at all, or it's increased the awareness that we cannot just think about the economic terms, but we have to more or less think more on the contextual aspect. And this is another Harvard team standpoint on the P4P. So within this magazine, so it's just P4P giving to hospital is just like giving a little solution to the big elephant. So this is may not be economically worth doing. So another publications I think in the CDC journal, that they conclude the evidence from the UK hospital that had already been made. They also said that this is because history bias, the bias because of the change of environment. Hospital tends to be improving in terms of outcomes anyway, without doing anything, because of technology, because of many other contextual framework. Then it may not be the P4P itself that increase the better performance of the hospital. And they put the conclusion on the doing, it's because the policy was never based on a good control experiment or the quasi-experiment at all. So these are some criticisms which say that P4P may not be good. So after a very long presentation, do you think it's good or not good? It's just like the quiz of if you use the case mix tool to pay for inpatient. We skip this because we already discussed yesterday on the CBG, inner CBG and DRG. How can you effectively control the overall cost of inpatient care? And the second question on the principal agency theory. So who is the principal, who is the agent? Is the patient an agent or a principal? Hope that you are not sleepy.